We would like to acknowledge traditional owners of country throughout Australia and recognise the continuing connection to lands, waters and communities. We pay our respect to Aboriginal and Torres Strait Islander cultures and to elders past and present. Welcome to a Vodcast series produced to support the implementation of the General Practice in Aged Care incentive. The new incentive enables the delivery of high-quality, person-centred care to people living in residential aged care homes by their regular GP and practice. The incentive is aligned with the introduction of My Medicare, or rather voluntary patient registration, which facilitates ongoing relationships between individuals, their GP and the general practice, and enables proactive, planned, continuous care. The incentive commenced on 1 July 2024. It's a major measure under the Strengthening Medicare Primary Care reforms and part of the Australian Government's response to the Royal Commission into Aged Care Quality and Safety. I'm Leanne Wells. I'll be talking with expert panellists across 4 sessions about the need for the incentive, what constitutes quality primary care in the aged care setting, the hallmarks of team-based care, variation in general practice and implementation enablers. Joining me are Dr. Paresh Dowda, an advisor on primary aged care and GP leader with a special interest in aged care, Andrew Haywood, Head of Workforce Strategy at the Aged and Community Care Providers Association, Karen Booth, a nurse leader, President of the Australian Primary Care Nurses Association and Clinical Advisor Nursing to the Australian Digital Health Agency, Sophie Puron, a Practice Manager from Adelaide, Dr. Anthony Marinucci, a GP leader with a special interest in aged care also, Anne Davies, OAM, a Consumer Leader, Layla Hallam, a Consumer Leader, and Kate Ty, Executive Manager, Primary Care Development at Nepean Blue Mountains Primary Health Network. Let's start with our first discussion, which explores the context in which the General Practice in Aged Care incentive has been introduced, the needs that drove its inception, the kind of care it aims to support, and the benefits of this approach. To make a start, I'd like to ask our panel about the current context for this incentive. Why is it important and why is it being implemented now?
Thanks for the question, Leanne. I think this incentive is important because it's really a response from the government to the Aged Care Royal Commission. The Aged Care Royal Commission very specifically heard, whilst there's good aspects of general practice care happening in aged care, many residents who live in residential aged care homes are perhaps not receiving that optimal primary care. One of the things I think people heard was the need for proactive, comprehensive, continuous primary care. And I think what this incentive is trying to do is help really take a step forward in that direction to encourage and incentivize continuous, proactive, comprehensive primary care.
And Andrew, to you, for an industry or provider, aged care, residential aged care provider perspective on the current context and the key drivers for this incentive.
Yeah, thanks for the question, Leanne. The drivers for this incentive are the continuity of care. Just acknowledging the number of residents in residential aged care that are looking for critical care from their GPs. Just acknowledging also that the demographic trends. So we've got an aging population with complex health needs, and they require sort of person-centered care, and emphasizing that equity and diversity in service delivery. And I think the GP incentive goes some way to actually addressing that.
Layla, to you, for a consumer and a family carer perspective on the incentive.
Well, of course, continuity of care and proactive services, but I'd even go as far as to say it's an opportunity for relationship building. I mean, it's actually building in an opportunity to resource GPs so that they can build relationships with the patients that they're serving, and or the residents as they're serving, particularly in aged care, where trust and relationship building is really important to older people who will do, who need that relationship in order to follow the services that they need.
On the health side of things, the incentive is a critical part of the Strengthening Medicare agenda. Karen, you were on the Strengthening Medicare Task Force. What's your take on the incentive?
So I think every visit is gold. And what we need to do is look at how we can encourage GPs and support them to be able to actually go to aged care, to have that continuity of care. And for me, part of these incentives and some of the other big picture things that are happening with the health reform is better connection for care. I think better opportunities for teamwork and teams to support better access to care and better input from other team members, but also that opportunity to support the GP who's supporting the patients. And also the poor old aged care staff who really have to battle sometimes to try and get access to care for their patients. So making sure the patient and the care facilities are supported along with the GP for a much better sort of bigger picture patient care for people.
Kate, I might come to you for your thoughts on this too, because, primary health networks, you work in a primary health network, they are, I suppose, multiple purposes and functions they fulfill, but a key one is supporting integration of the system. Your thoughts on the incentive and why it's important?
We have a growing ageing population, and the average age of an older person entering permanently into a residential aged care home is 86 years of age. And they have a number of comorbidities and therefore complexity in their needs. And the importance of primary health care can not be undervalued at all in any way. As a primary health network, one of our key roles, as you said, is to connect across the system. And building on what Karen said around the importance of communication and the importance of relationship with residential aged care homes and with general practice, that's critical. So that's a key role that PHNs play in that space. The other thing that PHNs do is work with general practice to assist them to implement and adopt new ways of working. And GPACI requires general practices to think a little bit differently about how they would provide care in residential aged care, how they use multidisciplinary teams, how they can really work together with the team in their practice, but also those other care providers that work within the residential aged care home.
Anthony, to you, you're a GP with an interest in aged care. What are the main needs do you think this is really going to help the system respond to better, this incentive?
So I think we all understand the theory behind excellent primary care and how important it is and how much of an impact it makes on patient outcomes. What I think the incentive aims to address is the cost of delivering that care. Currently, Medicare is a fee-for-service system, so we're remunerated every time we touch base with the patient. But as we know, good continuous care requires a lot of work outside of that. And I think this is one of the main issues. A lot of doctors find that they're requested to do a lot of work outside of those bounds of the basic consultation. So this incentive tries to aim to sort of remunerate for work outside of the fee-for-service model. So I think in that context, I think it's a very positive thing. And ultimately, if we can be a little bit more remunerated for all of the work across the board that we do, it might end up being a little bit more attractive for doctors around the country to continue working in aged care.
And I just want to come to you. There's aged care sector drivers for the incentive. There's healthcare sector drivers. There's clearly consumer need and demand drivers. How do you see this incentive being a positive thing and playing into, I suppose, the emphasis we hear all the time now about the need to step up attention to aged care quality standards?
Look, there's always been a great difficulty in attracting GPs to visit residential aged care facilities and to give care to older people. And this really is due to time constraints, remuneration, location, administrative difficulties, and also the perception that about willingness to practice in aged care. So I'm very excited about this incentive, and I think the introduction of the GP aged care incentive absolutely strengthens the quality of care in that consumers' own GP reinforces the continuity of care. They have a knowledge of the medical history and what primary care services have been required prior to a person's admission to an aged care facility. And they are able to give a more personalised medical care. So I think the GP is best placed to interact with the consumer, family members, and to facilitate shared decision making. And they're best placed to be a consumer advocate. So I think this is a most wonderful incentive.
Sophie, just wondering if you've got any perspectives from a practice management point of view on the incentive and how it's a positive shift.
From a practice point of view, I think that there is that aspect of consistency and continuity of care, but there is a recognition from this incentive that there's a contribution from the general practice towards the provision of services into aged care facilities, where, you know, the staff may not be visiting the aged care facility, the GP is visiting the aged care facility, but there's a lot that goes on behind the scenes from the general practice perspective in relation to the provision of facilities to services to aged care facilities. And I think the way that this incentive is structured is a recognition of that.
We've also touched on the principle, I suppose, of person-centred care. I'd just like to get, perhaps starting with Layla and then coming to you, Anne, on, from the person-centred perspective or lens on this, what is high-quality primary health care for people living in a residential aged care home?
And I think from a patient perspective, I think we can't underestimate the value a GP actually brings by knowing who the person is, not over medicalising the issues that they face, because generally speaking, they have a lot of stuff going on. But even so, what we want them to do is live their best life, even within and particularly within a residential aged care facility. So it actually wraps up a whole lot of things. It's visitation, it's relationship building, and it's making sure that they are living as good a life as they can and not focused on the medicalisation or the deterioration points. So I think that there's a lot of benefits from a patient's perspective to have that kind of oversight by people who know them.
And I think this means putting people and families at the centre of decision making and working alongside staff to get the best outcomes. And in this regard, with the incentive step, I think person-centred care will be strengthened, and certainly it will be under the new standards.
From your perspective, Anthony, how would you describe good quality primary care for people living in residential aged care?
So for me, I like to define, rather than saying patient-centered care, I like to say patient-driven care. So I think the most important thing to recognize is that we all, as we age, our focus of care or our care plans in our lives change. And often when people are admitted into a residential aged care facility, they tend to be towards the latter stages of their life. So often there is a very, very different focus on what we're trying to treat, or what we're trying to do with their care. So in that context, one of the most important things that is required is communication. And communication between doctor, between patient, between family, between facility. It's a very, very complex area, aged care. There's a lot of stakeholders, and often messages can get confused. So I think mirroring the thoughts of what Sophie said before, having the practice involved, there is often a lot of scheduling required to make sure that effective communication is in place. And then by doing that, we can set a really appropriate care plan in place, which is really the foundation of any sort of care model. If we don't get the sort of foundations right, then we can't really hope to deliver really good outcomes. So for me, I would say the absolute bedrock is effective, excellent communication and education to patients and families. And anything from there, I think you'll be winning.
Look, I think the aged care incentive payment is part of a big picture. And I think we have My Medicare, where patients who are enrolled will be able to have longer consultations as well, and more in-depth consultations for some issues. I think the GP incentive, the aged care incentive, will actually help focus on things that Layla said earlier about early intervention and prevention. And I know my role as a nurse in general practice, I loved doing aged health assessments. We do them in the practice, or go to someone's home and see them at home, or go to the aged care facility.
How does the incentive differ from the current way general practice and other members of the care team are remunerated to work in aged care facilities? How does it better enable the high quality primary care you've all just described?
From a practice perspective, dealing with previous incentives has always been a little bit tricky about how do you allocate, some aspect of it to the practice, how do you allocate some of it to the general practitioner. I think this incentive, for me, makes things a lot clearer. One aspect of it is very clearly directed towards the general practitioner, and the other very clearly directed to the practice. But it also, from a practice point of view, really does speak to that continuity of care, that as a practice, you really have to have a commitment to having a primary practitioner for that patient. And so it really enables us in terms of, I guess, quality control and quality improvement. It enables us to look at what's happening with that particular resident, and how that service is being delivered, and ensuring that it's being delivered in the way that provides consistency and continuity of care for that resident.
So I think this is threefold. I think what this incentive does is actually encourages GP engagement with the residential aged care. I think it provides financial support, which obviously motivates the GP to dedicate their time to residential aged care. And that in itself then ensures continuity of care. I think secondly, it improves integration. So it facilitates communication and collaboration between the GP, the aged care facility, the staff, the residents, the families, and provides that timely and consistent care to the older Australians. And then thirdly, it strengthens resources. So this can help implement systems and support timely assessments.
I think what the incentive does is to really get us to think in terms of practice-based population health. So we're now looking after a population of people who live in residential aged care home. So that's kind of the paradigm it's set. Within that, the registration system and linking it to My Medicare and voluntary registration, actually sends a very subtle message that once that resident is registered with us, we're accountable for their care. The formalization of that relationship, I think, with it brings clarity of role, responsibility, and accountability.
I've got a final question to ask. Thinking about the beneficiaries in terms of the people, thinking about the beneficiaries in terms of general practices and the general practice setting, but also thinking about the benefits to residential aged care homes and their capacity to respond and deliver in collaboration with the primary care sector to the needs of their residents. I'd like to ask, I'll start with Andrew, your thoughts on, in a nutshell, in an elevator pitch, the benefits of the incentive.
My elevator pitch would be the greatest benefit of the incentive that I see and that our members are reporting is that the potential for enhanced health outcomes. So improved management of chronic conditions, potential reduce of hospitalizations, and better overall quality of life for residents. Again, we've mentioned relationship building and multidiscipline teams all working in unison. So that sector stability is really important, and it's strengthening those relationships between care providers, GPs, and that consistent delivery, which is really beneficial and imperative. And then that in turn increases the resident and family's confidence in the quality of care that they're providing or being provided. So that builds trust in aged care, in the systems, and then ensures the comprehensive accessibility. And again, what we already mentioned, the person-centered or person-driven care is really then enhanced by the relationship and that confidence that grows in the level of service and care that they're being provided.
One day, we are all growing older and the population is aging. So at some point, there's a few of us around this table who will be in an aged care facility at some point. And I think what we want is to reiterate what Andrew just said with regards to relationships. I think relationships is really important. So moving out of a transactional medical relationship into a more relational relationship, I think will make a world of difference to the patient with regards to their willingness to share information about what's going on for them so that we get better diagnosis, we get better day-to-day management, we get better adherence to what is suggested that they do. It also means that our residents are having a better time of it. They're not having to sit waiting, knowing that there's something that's just not right, but actually not actually having access to the general practice to be able to come and talk to them. And I think from the perspective of it being a general practice thing, I think that whole team approach is beautiful. So this whole multidisciplinary approach right through to palliative care is a really lovely way and a gentle way for our residents to enjoy what time is left, to be cherished, and to come out with a better quality of life, with medicine not necessarily dominating their lives, but they're living with it to the end. So I think it's all about quality of life and better outcomes for them.
I think one of the important benefits is the opportunity for practitioner experience, and having an improved practitioner experience, because as has been discussed, it has been quite transactional in the past, and this really does drive working in partnership with each other, and GPs and general practices working in partnership with residential aged care homes to deliver the best quality care. And I know that care managers of residential aged care homes really value the support of GPs and the support of their teams in the work that they're actually doing with that individual resident. And I think what we will see is improved practitioner experience. The other thing is that it also assists teams to be able to, general practice teams, to be able to look at their patient cohort, understand who those residents are and which homes they're in, making sure that there are scheduled planned visits for those residents and that they are actually proactively managing their care and doing that because they understand what that patient cohort looks like, what their needs are, and that frequency of visit as well, but also who are the care teams that sit within each of those residential care homes as well, and what that looks like, because it looks different in every home, and that can be quite challenging for GPs. And as a PHN, that's certainly something that we can assist the general practice and also the residential aged care home on as well.
Thank you to our panellists for offering perspectives and insights on high quality primary care and the general practice in aged care incentive. This brings us to the end of our first session. During the conversation, our panellists have acknowledged that access to quality primary care has traditionally been out of reach for many people who live in residential aged care homes, reinforced that the incentive is structured to make a difference by remunerating more person-centred or patient-driven care, and they've agreed that residents will ultimately have better health outcomes and quality of life because of a more planned, team-based approach to the management of what are typically a very complex set of physical and mental health issues. Join us for our second session in the General Practice in Aged Care Incentive series on how the incentive can better enable joint working and team-based care for the benefit of people living in residential aged care homes.